So I've got a very much big change of pace. So as Sheena said, I'm going to talk to you about our project called PREXIT. The project was coined this term because of the Great Britain vote that was going on at the time. Unlike Great Britain, we didn't really get a vote because we had a rather large imperative to move into our brand new building at the Bright Alliance, which is at Prince of Wales Hospital in Randwick in Sydney. As you can see on the picture on the left, they're not our actual files, but it's the stock image, but we were very paper dense in our record keeping, as most, I guess, traditional records are. Because we come from a cancer genetics service, we're very typical of genetic services, which relies heavily on paper files. So this project was quite novel in a way because we had to consider all of the aspects around genetic records to do this. Just to show you where our actual location is, it's an open plan office. Now, it is very beautiful. I've got a lovely picture underground of Bondi Beach with a lovely mural in the background. However, as you can see, there's really no storage facility for any records. We've got very minimal for some resources, but it's tucked away down a corridor. But we had about 10,000 family records, and that was definitely not going to fit in our village, to use a coin a jargon term. So I'm going to talk to you a little bit more about what's different about a genetic record and why is it different to a normal general hospital record as well. The policies that we had to comply with and how we went about developing our solution, and ultimately implementation, which I'm pleased to say we managed to do to get into that new building. So to touch on genetic records, if we look at a typical hospital record, it really deals with one person. It's an individual record. They may vary in size or volumes, but it is all about one person and their healthcare, whether they've been an inpatient or an outpatient, all the different services they might access through the general public hospital. Now, with a genetic record, think of the family history that I've got up there. It's really about a family. So we may see multiple relatives, all about the one condition or a syndrome or genetic assessment to see what risk they are of developing cancer later in life. So as you can see with the red circles, these individuals might have all attended, maybe concurrently, quite typically over time, and this could be over a couple of decades. Our service has been in place since around 1994, so we have quite a collection of families. Now, in a family history record, we will have a pedigree, which is the family history record, which will look like that image that's up on the screen. We will also have information about people that have either passed away or live interstate, maybe across town, maybe internationally, and we are unlikely to ever see those people in our clinic. However, it's really important that we verify cancer histology so that we know what type of assessment we can give these people. So these family files can go from anywhere from a very small amount of space, maybe a centimetre big, to really quite large volumes that may be a couple of inches deep each. The other aspect of genetic records is they do need to be kept separately from general hospital medical records, and in the past there's been quite a big problem about genetic stigma and protecting people's right to have that information to themselves and not broadcasting it. There's also a potential for financial implication with insurance by having genetic testing. Now, we're in an era of change, and mainstream of genetic testing is entering all aspects of medicine, so that may change in the future, but really at the moment we're still probably on the cusp of where that change is. So genetic records have pre and post clinic contacts of the patients. They're also open-ended, which means that from the start we might get the referral, and the genetic counsellor might deal with that referral in a triage manner. They may have several phone calls before they actually come into clinic. At the clinic, they may only see the genetic counsellor to go through some education, maybe some testing, and then they may come back to see the doctor to get some medical advice input as well. And post-clinic, they then may have several phone calls, which may go from a few days later to sometimes several months to maybe 6 months later. So if you think of that as one occasion, that's what we had to deal with when thinking through the movement into an electronic era. So they generally may not have got discharged necessarily. So when we look at the comparison to electronic records for a single individual, which is now in place in our hospital, It's very much open the encounter for that appointment, and then it gets discharged as soon as the patient leaves. So that really wasn't adequate for us. This would be opening, closing records very regularly. Genetic records have also got to comply with Ministry of Health policies, and primarily about being kept separately and maintained confidentially as well. So one of the key things we had to look at is how do we maintain the security of those records within an electronic environment. The other factor as well is because you saw the multi-generational family history, we also need to keep these records indefinitely. So as you may know, with an individual record, that person following their last discharge from a hospital, the hospital can destroy those records for a period of time. It's, I think, around 16 years following the last discharge from the hospital. But obviously that's not going to be adequate in a family history setting, because we need to be able to follow grandma's history and have that available for grandchildren or great-grandchildren as they come through. So we're seeing the evolution of these families and people we met when they were 20, maybe now in their 40s, or we could have 40-year-olds now 60, and there's the new generation of being born. The younger generations at the time of first being seen have also now grown up and are entering an age where they may be at risk of cancer. So it's quite important to have all of this information accessible in the record. So the process that we went about was, I've touched on a few of the aspects that we needed to consider, but really identifying what the cancer genetic requirements were and thinking through how applicable they might be in an electronic environment. We evaluated possible solutions. Some of those were existing. The typical single patient hospital standard record had a lot of benefits in that the security was already in place around hospital side of record, but not for the genetic aspects of keeping it confidential. It was unable to allow for kindreds or family members within one patient record as well. We also had some systems in place for genetic systems. However, they didn't deal very well with all of the EMR type of compliance and the security footprinting and so on. So we were kind of at a loss. So it has been almost a 7-year project in the making to try and tie this in and wait for technology to catch up to where we need it to be. But as I said, because of the building advent, we really had to find a solution quickly. We had to send off briefs to the local cancer services management and the hospital executive management, and we decided to settle upon CHOC, which is a Cerner-based product. It's a community health outpatients care module, and currently at Prince of Wales we use PowerChart, which is also a Cerner product, so it tied in nicely with an existing hospital-based system. CHOC allowed us to have these open encounters as well, whereas in the PowerChart it's really open and closed for around that appointment time. I'll touch on briefly that we really looked at this as a prospective model, and that's what we've rolled out in. We did have to do a 10 to 21 years worth of records retrospectively, and so we've actually used an ADEX solution, which is a bulk scanning web-based login system to access those, but I'm not going to touch on this for this talk. Other competing issues were going into the new building. The cancer services that locally were pooling their admin resources, and so we had to think about how do we minimise new systems for multiple admin needing access to these. We already had in place the cancer services EMR is called Mosaic, and so that worked very nicely, but it didn't meet our security needs, unfortunately. We also have a genetics database that's statewide, but it also wasn't compliant with EMR, so we weren't able to go forward with those systems. And obviously we had the imperative of time. So as part of the evaluation, we had to comply with also the hospital medical records policies. And so having had satellite records, so to speak, prior to now, they weren't necessarily compliant with what today's standards of medical records needed to be. We also had to work out how to link the family members. And so CHOC was able to develop for us an M page, which I'll show you in a few slides, so that we can actually see which relatives are actually part of each family and have ready access to find those quickly. We also had to go through a process mapping, looking at how our whole department flow is, looking at from the patient's perspective. So that was the butcher's paper model. which then got converted into a swim lanes chart, and I'll show you a snapshot of that. And we were looking at every stage a patient might come through our service and touch any of our staff members. We also had to comply with digitised scanning records as well and policies. So that's an example of how one patient, there's a couple of excerpts there to fit them all in to give you an idea, because otherwise you'd see admin for quite a while. We needed to also use an event set hierarchy. So we modelled that on existing event set hierarchies within medical records policies already. What that really means is how we can code our documents for scanning in, so that it's not just getting all scanned in as document 1, 2, 3. So we had family history, we had histo, and so on. We also had local processes in place for the outreach telehealth service that we run, as well as for a high-risk clinic. We're still in the process of evaluating what the costs were, but obviously we're trading some stationary costs and physical manpower of retrieving records and so on. We also needed to develop forms so that it could be appropriate for government printing, so that would comply with EMR policies. We also had a small problem with abbreviations. The hospital didn't really have very many genetic appropriate abbreviations or acronyms. So DNA in a genetic sense has obviously got a different meaning to the stock standard did not attend. We've got some processes in place when our pathology colleagues catch up with their software so that we can get our online ordering in place as well. On this slide, I'm really going to highlight over on everyone's far left, where we've got a traffic light. It's a very small dot at the furthest arrow. Our admin really rely on this, of being able to see red means they need to do something immediately. Orange or amber goes to that they're waiting for the patient to get back to us, and so on. But we're able to assign different staff members along with our hereditary cancer stream, and we could follow their progress there as well. So the genetic counsellor will triage. We can see that there's gaps where nobody's been assigned, so we'd go straight to those and assign it to admin. It's already using the existing appearance of the power chart model, and it also integrates any other occasion seen by other parts of the hospital as well. We also had to attend to what do we do with those relatives that we're never going to see with the information we have. So we made a decision to code those under a relative of the first person in the family being seen at our clinic. And so we still use a genetic database for the state as we need to, so we use these in parallel to be able to track these. That's the example of what the M page to link the kindreds is. So we get the genetic file reference number, as well as what the mother's name in this example, I had to de-identify this, and the date of birth so we can track them. So when we did roll out, the first challenge we had was people in transition. So we had some people that had died and we didn't have an open encounter in the secure genetic area. And so thankfully there's only been 1 or 2 of those, but it did present an initial problem there. We also need to discharge the service eventually because we can only hold 1,500 open encounters at any one time. But we're sitting around 400 typically each month, and we're a good 6 months down the track now. We have noticed, though, there is a significant demand for scanning for our admin team, so that we've probably traded the file retrieval and the stationary physical manual part of it to a different style. We did review this very regularly to make sure that the processes we thought 12 months ahead were actually working, and it was a big surprise to us that we actually almost got it perfectly right, but tweaked it a little bit. And we continue to evaluate that to make sure everybody's working well. So in terms of the biggest benefit is the instant access, and that multiple clinicians can see all the record all in one go, and that includes our admin as well. So admin aren't waiting for a file to come through so they can actually file a letter away. But also when a patient or a doctor rings, we have that instant access. We don't have to wait for admin to retrieve a file for us, so we can actually attend to that call. There's obviously stationary cost savings, and also the biggest thing is that the family record's in a single patient environment. And lastly, I'd like to thank the team, and I'd like to point out Robin Cook, who's the top in the portrait mode at the top there. She started the project management, and then it was taken over by Katie Bowden, who's in the bigger picture to the far right, who saw the project to completion with a lot of help from second to the left Melitza in our team. Thank you.